Market Access Committee. It's a pleasure to welcome you to today's Market Access Forum. Thank you so much for taking the time to join us. We recognize that the healthcare environment is under immense pressure, and discussions like this that will be taking place today assist us as we navigate the future of healthcare procurement in South Africa. Today's session continues on an important conversation that began in our previous forum, which is on value-based care procurement. Across global healthcare systems, procurement is continuously shifting. Health systems are no longer just about asking, what does it cost? But it also has the other arm of increasingly asking, what value does it deliver? So in essence, with value-based procurement, we are not just looking at the policy concept, but it is essentially becoming a practical framework for how healthcare technologies are evaluated, contracted, and essentially adopted. So what does it mean for us as medtech suppliers? It essentially allows for a shift fundamentally into changes of how we can compete successfully whilst looking at demonstrating clinical value, providing economic evidence, supporting patient outcomes, which better patient outcomes, that is important, and also partnering more strategically with healthcare systems. I'm sure we all know that South Africa is still in its early journey in this arena, but the signals are there and they are quite clear. So today we'll be looking at understanding how other systems have implemented value-based procurement, including their successes, challenges, and lessons that they have learned over time in implementing value-based procurement. So in today's discussion, it will help us to move from theory to practice. I think all of us can take away what will be valuable for us, and it will just give us insight of where to start as we prepare for ourselves. Before we start the session, I'd like to just highlight some housekeeping. The session is being recorded for minute-taking purposes. So by participating, you consent to the recording. And also just a kind reminder to please declare any conflict of interest or recuse yourself as soon as it becomes obvious, and where necessary, please just to indicate by raising your hand. Nomti will be managing the chat. The meeting is conducted in full compliance with competition law. Please avoid discussing any commercial, sensitive, or non-public information, which may include pricing, costing, strategies, supply terms, or distribution plans. This applies to before, during, and after any summit meeting. If at any point you believe an improper discussion is taking place, please raise it immediately. We do encourage engagement, so please make use of the chat or the Q&A function to submit your questions during the session. If anything remains unanswered, please Nomti will gladly show your questions, and then we'll revert to you with feedback from the relevant speaker. Today, we are quite fortunate to be joined by valuable speakers that are in our midst as per the program displayed on screen. These are colleagues who have charted the territory on value-based procurement, and they will be giving insights into their experiences. They will share the real-world insights of how value-based procurement has been implemented within the UK National Health Services. They will also share the challenges that they have encountered, as I have alluded before, and the lessons learned from there. The session will be led by Brian Mangan, who will also introduce the panel of speakers that we have in our midst that will be joining him today. I'd like to just do a little bit of an accolade highlight for Brian, who's amongst us, and our lead speaker for today. He is the Chief Executive Officer of Loog Consulting Group. Brian is an internationally recognized expert in value-based procurement with extensive operational and strategic experience working within the UK National Health Service. He has supported health systems and industries across Europe, North America, the Middle East, and Australia, assisting them in embedding value-based procurement into real-world practice. Brian will begin today's session by reflecting on our previous value-based procurement discussion, which took place about 2 weeks ago. He will also be sharing feedback from the MedTech value-based procurement self-assessment tool, and will also be introducing the UK National Health Service leaders and industry practitioners who will be joining him in the panel today. Brian, thank you so much for availing yourself into sharing the insights, and I'm sure we are all eagerly waiting to hear what you will share with us, and we will all draw from that into practicalizing it within our own environment. Over to you, Brian. Thank you.
Thank you very much again for the invite to come back. I didn't know after the last session whether I'd managed to. I just said before the meeting, I spoke for the best part of an hour, and there were very few questions at the end of the presentation, so I wasn't quite sure how well it went down. But I say it's really do appreciate the opportunity to come back to see you again today. So as we said, today's session, it's very much just a quick review from me about what we covered just a couple of weeks ago, and then to give you an insight into the survey, which a number of you kindly completed. And then I've assembled the value-based procurement dream team from the UK. We've got Erica Isherwood, the clinical procurement matron from Mersey and West Lancs, who's going to be talking about her work over the last couple of years on VBP, about the role of clinicians and patients in value-based procurement. Then I'm going to do a fireside chat. Ian called it before. A bit of a Q&A with Ian about his experience at applying VBP at a national level. And then concluding with Jason, who's the CEO of Airglove Medical Limited. I've had the pleasure of working with Jason for a number of years in one of his previous roles, and also continuing that. And I think it's going to be really interesting to get Jason's perspective from as a supplier about the challenges and opportunities of applying VBP in the UK. So really what we're hoping at the end of the next hour or so, hour and a half, is that you're going to get some practical advice, that you'll have some insights about, we talk about value, you talk about value, and it's quite conceptual. And what we'd like to sort of give you some hope is that by really sort of taking on board some of the challenges and some of the opportunities that we've been through, is that you can actually begin to apply this in South Africa and realise the benefits. So that's what we're aiming for. If you could, please do put some questions in the chat. So we're going to have a bit of a panel discussion at the end, and try and sort of pull it together to give you an idea about how you can take value-based procurement forward in SARMED and across South Africa. So very quick recap of the last session. I talked about value-based procurement and how it aligns to value-based healthcare. So for me, value-based healthcare is a concept that's been around for a number of years, probably since about 2006. It's really only been adopted in sort of pockets, if you like. And what I see is that by looking at value-based procurement, it's this stepping stone. It's this stepping stone and a real mechanism for creating change, that people can sort of realise that there's opportunities to work with industry, not only to reduce the total cost of care, but to improve patient outcomes and make health systems more efficient. We then sort of looked at the benefits and opportunities. So I did a couple of slides on individually what it means for the South African health system, and potentially what it means for yourselves. And again, the reason for putting those slides up was I thought, well, if you're going out and you're speaking to health systems, you might be able to use that as a bit of a tick list and bring it into the conversations to say, do you realise that, when we're looking at value, it can really improve the lives of patients. It can improve the lives of clinicians as well in terms of delivering improved patient care. So say for me, it just hopefully gives you a pointer. So when you get going out and you're talking to health systems and procurers, it gives you more ammunition to be able to say, this is why we need to look at value and value-based procurement. And then obviously I then shared a little bit of the work that's been done internationally around the implementation of VBP. And this session is really sort of to try and build on that and give you, real life examples from people who are actually going out and delivering this. I'm going to be sharing with you the feedback from the self-assessment survey that we sent out. And the purpose for that, I was going through it with you, there was kind of 6 stages to it. And for me, based on the experience I've had over like the last 5 or 10 years, it's saying, okay, there's some fundamental elements that you need to consider if you're going to create a value-based approach for your organisation. And it was there just to get you to start thinking about that. And we were keen to see really kind of what stage the SAMED members were up to. So in terms of the actual the questionnaire, Nancy kindly sent it out for me a couple of weeks ago, and she did a great job in making my self-assessment tool into something that was quite simple, I think, to understand. And we asked for the returns to be sent back to us by the 5th of March. And unfortunately and kindly for everyone filling it in, we managed to get about 13 responses. So we do appreciate people spending the time to do that. And the way that the questionnaire, for those of you who didn't see it, the way the questionnaire was structured was, say, it took the 6 points that are discussed at the last session and split it down into a series of questions. So the first one was about getting an understanding about, has your organisation recognised the need for change, and also have you identified in South Africa again that your health system is beginning to look at a value? So that's what those first 3 questions were about. The second one was about, is your senior leadership aware of VBP and are they bought into the approach? So obviously with any change project, this is what this is, you need the senior leadership buy-in, because they can obviously help progress the project and make the necessary investments going forward and help you overcome any barriers that you might encounter as well. The third part of it was about trying to get an understanding about whether you as industry have got many examples about where your products and solutions can add value to your customers, and if you can measure their impact as well. So it's trying to find, I suppose, which state you're at the moment. What solutions have you got? Have you got them written up into some kind of case study that you're beginning to share with the wider healthcare community? The next 3 questions were around, the first one was about generating support. And this was really to try and understand whether you'd started speaking to external stakeholders. So whether you'd started having conversations around value with your customers, whether you had a plan in place to do so. And also to get a bit of a view around incentives that you might have for your staff. Whether you've got incentives, whether they're just sort of short-term, sort of sales and price-based incentives, or whether you're beginning to look at ways that you can really try to motivate your teams by considering aligning incentives towards value. Then the 5th one was about, are you committed? And that was really to try and sort of determine where SAMED members were on the journey towards value. Whether you started, beginning to plan, whether you're going to start investing in VBP, really just get a sense check about, well, where are we up to? And I do appreciate that as it is an early stage, is reflected by the comments that we've got back. And then the final one, Evolve, was for those organisations that are looking at VBP. You know, what mechanisms have you got in place to take it forward? How are you going to really start to look to embed value into your processes and into the South African health system? And the way that we constructed the questionnaire was basically around three simple answers: either not yet, whether you were exploring it, or whether it was implemented. So the feedback was, again, for the first one, to create the need for change. What we found there was that there is actually sort of strong recognition of the need for change within the organisation. And also, I believe that you've got a very good insight about the challenges that exist within the South African health system, about the areas that you need to focus on. And we had an awful lot of the respondents who are either exploring it, and a small number that are actually beginning to work to implement this need for change within their organisation. There was, in my previous presentation, I shared the fact that one of the metrics that I used to try and resonate with procurers to get them to change was a simple metric based on the ratio of saving schemes by the rate of return. And by that, I meant that when I did an analysis of the saving schemes in the UK, we found that about 70% of them were generating savings of less than £10,000. So there was an awful lot of activity going on for very little return. And that is like a motivating factor. I think it'd be interesting for you to consider, you know, what is it that can really get the spark of your potentially your people, your representatives, to say we need to start doing something differently. And it might be the fact that you've got a reduction in sales, or you've got pressure on your profits. But again, that was just one area that we looked at. But again, very positive in the fact that you recognise the fact that there's need to change in your organisation, and also that the health system is looking at it as well. In terms of leadership buy-in, again, it was really, really positive. There was the senior managers and leadership are kind of interested in value, which I think is great. And the reason why the numbers look a little bit skewed, where we got 28% in the red, was that one of the questions that we had on there was, have you got any governance processes in place? Which obviously, because VBP is at a fairly early stage, then that really isn't the case in many organisations. But the overwhelming response to the first two questions that I asked about, are leaders up for value, and our senior managers, that was resoundingly positive. So that, I think that again is a really positive sign that people are open to looking at value. When it comes to providing evidence that works, I was a little bit surprised about this, because I know that you've got loads of examples. I'm certain that you've got tons of examples of where your products and solutions actually create value for the health service. But doesn't appear to be many organisations that have got like case studies as a way to demonstrate the value, to be able to share with organisations that with the health system that you're actually beginning, you can deliver value, and this is what it actually means. And again, it come across from the results of the survey that you weren't really sure about how to baseline the current performance, and also understand what the measures were. So I think there's a bit of work that needs to be done on that. Definitely, again, I've found using case studies, as my colleagues will discuss in a moment, it's something that's really powerful. It can help you, and it can help create this change within a healthcare organisation to recognise the benefits that are actually being delivered. So I think that's definitely an area that we need to focus on going forward. The next question was about generating support. And again, I suppose it was quite unsurprising, really. I think at the moment, value for the SOMED members is something that is quite novel. It's quite new. And we had a conversation just before we started the webinar. It's just being introduced. So I suppose it's not really surprising that you're not actually going out and engaging with the wider stakeholder community because people are just trying to understand what it means to your organisation. So we didn't have any respondents that had actually implemented a stakeholder engagement plan. I think people are just trying to reflect and understand, well, okay, we need to work out what it means for us. And when we've done that, then we can actually go out and we can actually start engaging with the wider community. So say that was, again, not really, it wasn't unsurprising. It's kind of reflected of what we thought might happen. But there are a few organisations out there that are beginning to look at workforce incentives aligned to the delivery of value-based solutions, which again I thought was quite interesting and quite a positive step forward. So the final two about being committed, and this is where again we actually kind of got organisations to consider about reflecting about, well, okay, where could we start looking at it? Where could we actually start looking at VBP? So we know there's no case studies, but people are beginning to go through and understanding their portfolios about what are the products, what are the solutions that they've got that could really align to this value story that we're trying to promote. There were a small number that actually implemented, some and exploring, but the rest at the moment haven't done much about it. But again, I think after today, maybe it's something that you can go away and you can start having a think about, well, okay, what is it that we've got? And I'm certain that you've got products and solutions that can align to value, something that I've mentioned a number of times. It's just going through and trying to pick out that nugget of information, that sort of thing that can really trigger and say, you know what, this is the thing that we know we can articulate that really makes a difference to the health system. It's not just about the price of the product or, you know, its general application, but it can add value around efficiency or patient care and reducing total cost of care by using our product or our solution. And then the final one, again, it really is, again, reflective of the fact that the VBP is at an early stage within South Africa. So this was around evolving, and it was based on the fact that if you are beginning to explore VBP, if you are beginning to get a program set up, what are you doing to take it to that next level? So again, I suppose really it was a question of a number of people are just beginning to look at value, so they're not even at a stage where they can evolve it because they need to start. So I think, again, it's kind of self-explanatory in the information that we got back from there. We did have some comments, which again I really appreciated. There's a couple of people are looking at opportunities. Again, I think we've got a number of people on the call, so it's great the fact there must be some interest in it. I think we do need to look. There was a really great presentation from the last meeting that we had, which someone was talking about the health technology appraisal and the health technology assessment. And I think there's definitely synergies between the two. So there's that. And then in the interest of transparency, because I am transparent, someone said they thought the questionnaire was a bit strange, which I don't mind. It was that the questionnaire itself was actually constructed from a self-assessment tool. And I think that's where some of the questions might have got a little bit lost in translation. But again, I did appreciate the comments anyway, and it did make me smile. But we had a number of responses, and hopefully if you can see that it's given us some ideas about how to take things forward. So if you look at the graph on the right-hand side, what you can see, I think, again, the majority, it's quite positive. We've had a number of people who are exploring it and beginning to implement. So I think that's really positive. And the fact it's a new concept for you, I think, it's for me, it kind of really resonated very positively for me. I think there are 4 things that you might want to do to consider going forward. The first one is about engage. I think there needs to be a piece of work done about engaging wider with industry and health systems and senior leaders about the benefits of value-based procurement adoption. I think there's probably a bit of a programme of education for healthcare and suppliers on the principles and application of value and its alignment to HTA as well. So I think there's some work that could be done on that. Evidence, I mentioned before, when that I was surprised that there wasn't more case studies out there. I think there's loads of things you can do on that, and it's really powerful. I think there's an opportunity to create this library of case studies to prove out products and solutions of creative value. And I think once people can see that, it's like they can touch and feel it. And they say, you know what, this actually makes a difference. And then the final one is about really trying to look to embed, and that is probably done from a strategy level. So it's probably trying to develop, policy statements and governance mechanisms that really help support and embed value-based procurement and value-based healthcare into both industry and government as well, and trying to create this business as usual, value-based procurement is business as usual going forward. And that's me. So I hope that was okay. And so if you got any questions, please drop them in, and I will stop sharing for a moment, and then we'll introduce Erica. Are you ready, Erica?
I am, Brian.
Right. I don't know how this is going to work. I don't know. I'll spare with it a sec. I'll share the slides again. I'm hoping your smiling face will come up when I'm sharing my slides, and I'm not mad. Right. Okay. No, there's a moment. Right. Is that okay? Can you see that? Yeah.
Yeah. Thanks, Brian.
Okay.
Do I just say next slide, please? And are you my slide fairy?
It's gonna be. I'll be driving it. You say next slide. It's gonna be like like the COVID days in the UK. We used to have the press. Yeah.
Well, thank you, Brian, and thanks for that introduction. And hello, South Africa. My name is Erica Isherwood, and I am Clinical Procurement Matron at Mersey and West Lancs Teaching Hospital, which is a hospital that has 5 hospital sites in the northwest of England. Next slide, please, Brian. Oh, thank you. Now, everyone, I wanted to introduce you to a very important person. This guy is called David, and David gave a really, really powerful patient story, because I want to bring this home because it is all about the patient, and that's why we're all here at the end of the day. So David is a 60-year-old man, and he retired. Soon as he retired, he pretty much found out he had cancer, and that's terrible, but 1 in 2 of us will get cancer in our lifetime, so the odds are there, aren't they? So David found out he got cancer, and David has the world's most rubbish veins, and he knew that pretty much instantly. He needed to have a year's worth of treatment, and we caught the cancer early, and so that's what he had. Now, to have his chemotherapy and to check his bloods, he needed to come in twice a week, once to check bloods and once for chemotherapy. He has the world's rubbishest veins, so he would need multiple attempts to get a cannula in to take those bloods to give him his chemo. So David opted for a PICC line. So a PICC line is a centrally inserted central line, and that goes straight into one of the main veins. That line is a bit more expensive than a cannula, but it can stay in for up to a year. So that's what David had, and this is our value-based procurement story. The value for a patient of a PICC line is David could go on and live his normal life. David's time in hospital was minimal and really, really quick and speedy. He didn't have to have painful procedures because he had the PICC line in. The value for the hospital and for the staff was they didn't have to waste loads of time trying and attempting to get a cannula in. They didn't have to waste loads and loads of equipment. Think about sustainability value as well. And then a procurement value is, we've actually saved money by putting in this more expensive PICC line into David. So it was a win-win-win kind of scenario. Next slide, please, Brian. And I just wanted to tell you about the power of a story. So we took David's story and we filmed it. And David was able to express his gratitude to the Lilac Centre in St Helens Hospital. And he said he felt so proud that he could make that difference. He spoke about his experience with cannulas versus PICC lines, and then the staff were able to be filmed and speak about their experiences as well, which was wonderful. And then we got to come in and talk about efficiencies at scale. We then got the opportunity to go to NHS Supply Chain HQ and present that story. And so this is how stories can be so powerful and the ripple effect they can have. That story is now talked about in the National Cancer Plan for England, because actually it's a bit of a postcode lottery. Not every patient who has cancer is offered a PICC line, because not all hospitals have that ability and that service. So this is what we're talking about: value and efficiencies at scale. This is value-based procurement at its finest, and it can make a difference. So don't give up, guys. It's dead important. Next slide, please, Brian. You're doing really good. Thank you, glamorous assistant. And I just wanted to tell you, everyone, that value-based procurement it's just change, and we do it all the time. I think we've got ourselves in a little bit of a conundrum about it, but actually all I tell my clinicians and my procurement staff is it's just change. So we've got that agency because there is no more money, and I've swapped a widget to the cheapest widget 1,000 times over, and I'm at the end of what I can do price wise. So we've got that agency and we've got that vision, and we're able to communicate that, and I'll show you in a few slides how we do that. We've got our quick wins and we are shouting about it, and we're at the stage now where we're really trying to embed that as our culture. Next slide, please, Brian. So step one, what do I need from industry? Okay, the product. Tell me something that actually works and makes a difference, and then you'll get my attention. Okay, so just outline the basics. That's all I need to know. I don't have a lot of time to hear lots and lots of waffle. Just tell me why it's dead good and why it's dead important. And to conduct that market research. So what else is out there? Is this product something that is new and innovative? And get that feedback and data. Speak to loads of people, gather that data. It's so important that qualitative data and quantitative data tell the story as well as tell the figures. I've got to win hearts and minds. Here's a little picture about some gloves. So these are one of the first things we initiated as a value-based procurement exercise. A little bit more expensive, but we'll use less. Therefore, we'll have overall saving and a sustainability saving as well. Next slide, please, Brian. So how do I communicate that? I can communicate as a nurse, I can communicate to the clinicians. That's no problem, really. The communications, it's all about better patient outcomes for a clinician, and they understand the patients at the heart of what we do. My finance colleagues and my procurement colleagues, they want to see the hard facts, they want to see the data. So Brian's created this triage form, and it's on our NHS supply chain, and that's what I use all the time. So finance and procurement are used to seeing a kind of the same thing. I don't want to confuse them. They're a bit diva-esque, and they need to understand that this is the best thing to do. So is it tangible? What are the clinical benefits? What is the return on investment? How do we integrate it? Can we give assurance? And I need some granular detail. So we'll do a trial in the hospital, and then we create that evidence. Next slide, please, Brian. And then we do have our trials. So I love a good trial. I've got about 3 trials going on at the moment in our hospital. So we need to have a trial to evaluate the product, and we need to make sure they're conducted effectively to provide them meaningful results. Trials are always really not too tricky. Getting the evaluation forms filled in and the data from our staff who are so busy, that is the tricky thing. So you've got to make it fun for them, make it easy as possible. So we've worked with Jason, who's on the call today, and we've trialed the air glove, which we're going to purchase. So air glove is a I'll let Jason tell you about it probably. Actually, it's a really good innovative piece of equipment, and that is helping our patients. So in the feedback form, we see why it's good for the patients, why it's good for the bank. And Jason, I can talk more about it after if you need to, but I don't want to steal your thunder. We've got to gather that feedback, and that is going to go into my triage form, and that's how I'm going to go to finance and say, I want to buy this thing. Clinician feedback, dead important, but I also want to get patient feedback if it's touching and hitting a patient. Next slide, please, Mr. Mangum. And then step 4, so we're going to implement. So I've bought my product now and it's in the trust. And what do? I can't just lob a new thing in there and think, okay, goodbye, and expect it to be successful. We've got to provide training and support for our staff. We've got to have a rollout plan if we're going at scale. And I need, as the responsible clinician, to have a risk log, an action tracker, and I've got to keep their metrics up to date. And we have lesson learned reviews, and we have all these different meetings afterwards, and we help triangulate that data. So if we're doing something, is that helping me hit my quality objectives as a trust? Is that meeting patient experience objectives? And does this affect CQC inspections in any way? And each thing we do implement does really link in with all the different ones. And we've got to monitor and evaluate it constantly. And the companies that can help me do that are really some of the best companies to work with. That makes me want to work with you more. We've got some awards. So if awards has done really, really amazing with a new product, because it is all about change and change is hard, you've got to reward those early adopters. So we have prizes and we have quizzes, and then for engagement, we do lots and lots of engagement with staff in formal meetings. I have my ward manager and matron meetings as well, but we do engagement stalls as well. Of course, I've got 5 hospital sites, sometimes change. It'll affect a few hospitals really well, but maybe another hospital I need to focus on. So that's where we'll do our engagement stalls, and we'll speak to our clinicians face to face, and that face to face impact makes a difference. Next slide, please, Brian. And then it's all about change. So you've got that power to make a difference. Small changes, baby steps. If you've got in and done a trial, but maybe your trial results aren't as effective as you want, maybe we need to do a bigger trial. Maybe we need to do a longer trial. Not everything is a week's trial. Sometimes it's 2 weeks, sometimes it's a month. We've got to emphasize our progress and reframe our thinking. So we've got to make friends with finance. You know, find your crew, and they're out there. If you get one engaged clinician, you're well on your way. And then just think about the story, think about David's story. So we've turned his really horrible cancer experience into something amazing, and he's made a national difference, and that's amazing. And then just persist, guys. That's the one thing I want to pass over to you. Nothing changes if nothing changes. This is like the future of modern healthcare. We've got to think about value-based procurement, and you can be that change. So just stay committed, stay motivated. And I think I've run to time. Sorry if I've gone over, Brian. Next slide, please.
You're okay. You're good.
Okay. And I was just saying, thank you so much, everybody. Any questions I can answer in the chat, or we can talk later when we have our panel discussion. But believe in yourself, and think about that patient. If that was your mum or dad in the hospital, if that was your child, you would want the best product for your relative, wouldn't you? And that's how we treat every patient. So make the difference. Thanks, Brian.
You're great, you are.
Thank you, Brian. Guys, when I was a brand new clinical procurement specialist, I met Brian about a year ago, and he just adopted me. He is like the godfather of value-based procurement, and he's the best thing ever. And I think that he's part of the reason why we've been so successful, just because he's so committed and motivated. And any quick question, he just knows the answer. So, like, I'm honestly, I've said it a million times, just persist, and I'll reach out to Brian. Make your friends, make allies, and that's make the difference.
Yeah, I'll pay you later, Erica. Erica's the queen of VBP. I've put that on LinkedIn a few times as well. No, thanks for that. Again, usually, as you, a really good, insightful presentation. I know that there's already been some comments about saying how good you are on the Erica. So yeah, you're now an international VBP star. So thanks for that. Now we're joined by Ian.
Hi, Brian.
Hi, Ian. How are you doing, mate?
I'm doing very well, thank you very much.
Do you want to just do a quick introduction, Ian, about who you are?
Yes, hello everybody in South Africa. My name's Ian Dodd. I am the surgical engagement specialist for NHS supply chain, and I work in surgical mesh, wound closure and surgical instruments. Just a quick plot of history of my background. I'm a ODP by clinical training, and I moved over to the dark side in procurement many years ago. So I've got both clinical experience as well as procurement experience as well. And from that perspective, I wanted to really get to the grips regards to value-based procurement. And I think I've known Brian now for 8 years now. Brian, is that correct? About time?
I'm sure it feels like longer for you, Ian, but it normally does.
So
Yeah,
I think go on.
No, it's about 8 years, yeah.
Yeah, it's about 8 years. And we started it in, from nothing in this space in the NHS. And from a strategic perspective within the NHS, we in supply chain supplied goods and services to the whole of the NHS, and we served 300 acute trusts and all community services as well. And based on my role within supply chain, I write specifications for tenders, but also have an understanding of how value can contribute to the better outcomes regards to patients, etc., as per Erica's conversation earlier on. Right then, Brian, fire away.
No, I suppose really it's just about sharing. I mean, the purpose of today is to try and give a bit of an insight about, sort of maybe your experiences of looking at value. And so we did what Ian was involved early on when designed and led the NHS supply chain project. We needed to engage with the various leads from the different categories, and it was an area that Ian was quite interested in. And I thought it'd be good, Ian, just to sort of, I suppose, give you experiences about maybe some of the projects that you've worked on, some of the challenges that you've had, because people are interested in the warts and all kind of thing, and how you've overcome them and what you've delivered. So it's just that maybe you might want to pick a couple of projects or one project, and really sort of give people an idea about, okay, how did we do it? We went through the pathway process and things like that, but maybe go through an example, and then we can have a discussion about how that came out. So say really at the end of the next sort of 5 or 10 minutes, the members have got an idea about, well, how does it actually work in practice?
Yeah, no, not a problem at all. I could take 3 hours up on this subject, to be honest with you. So I'll try and get I'll try and get down to 5 to 10 minutes, to be honest with you, because it's been a long journey. Again, as Erica said, there is a patient at the end of all this, and as an ex-patient myself, the stress of going through a process of either having an operation or a procedure is quite upsetting, and you want to ensure you get a good outcome. And we have technologies and solutions available now where, yeah, okay, they may be a little bit more expensive. However, the surgical outcome can be very good. And I've worked in the space in surgical mesh, where surgical mesh is an implant within the body, and it repairs a hernia or a defect, as you would call it. And I've been concentrating on something called complex abdominal wall, where potentially, unfortunately, patients had certain types of mesh fitted, and unfortunately, they had recurrence. And we worked through that project, and like what Brian mentioned, we worked through a pathway. And as a part of that engagement, I thought it was clear, from using my clinical knowledge, etc., and working with surgeons, is to engage with the surgeons. And it's something which, if you think about it, you actually enter in a quite significant arena where these individuals are very, very well educated. And you don't want to upset them, because if you start upsetting these individuals, you don't get a way forward. So we went through that process and had these conversations with the surgeons to get them aligned. And I was quite lucky in the fact that it was a well-known issue where patients were getting recurrence, patients were having to come back for further surgery. And we worked as well with a small medium enterprise as a part of this process. So we had collaborative alignment across both the surgical community as well as the commercial community. However, one of the biggest things is the fact that we had to develop the evidence as a part of the pathway to understand what the actual benefits were of that patient not coming back for further recurrent surgery. And as a part of that journey, as I mentioned, we aligned with a consultant to go through that process and use his audible data, but also use commercial as a part of that process. And it was key from that, in that we got a good outcome, we got a case study from that, but also we got financial data as well as a part of that case study, to give a clear picture of what the benefits of switching from one product to another product. And again, there's always a patient at the end of this journey, and to get adoption in this space, because if you think about from a strategic perspective, I'm working across the NHS in this space, and we had to get financial sign-off as a part of that. So we sat down with the chief financial officer, and it was quite interesting. We worked at an ICS level, so in other words, within a group of trusts within the Northwest. And it was quite interesting when we sat down with that chief financial officer, chief executive. He says, "Guys, you're under-egging this." And I'm thinking, whoa, what are we under-egging? But again, it's social value in relation to the patients going back to work, etc. You haven't included that. And unfortunately, some of the touch points, so what I mean by touch point, a touch point is a part of the process, part of the pathway, where basically a patient has an activity, but you can't put financial cost against it. Therefore, he wanted to try and get us to drill down further to try and ascertain the costs associated to it. So it's easy to look at a product, it's easier to look at, like, for example, reduction in anaesthetic time, etc. But patients, when they're off sick, they're out of work, they're not contributing to society. So we've gone through that first pathway overview, and when we get to the point that the actual finance director actually sat down and signed that off, and it was, well, it was a eureka moment, I must admit. And looking at what we actually did then is we went to look at the national picture of how we could implement. We also work with the national clinical associations, such as British Hernia Society, Abdominal Wall Society, where they had a huge membership of consultants who were actually using the products, and they got a lot of experience in that arena. At the moment, we are rolling out across the NHS with this project, and we are getting certainly significant success regards to consultant groups who will want to use the technology. I'm quite lucky in this space, in the fact that consultants understand what the outcomes of these patients are required. They don't want these patients to come back into the healthcare economy. So they realise by switching to another technology will benefit those patients. That's quickly, sorry, I might have taken a little bit longer than I should have, but like I say, I can speak at length regarding what our experience.
Oh, it's great, isn't it? You know, when one of the concerns I think that STRAWMED members have got is that people in procurement don't get it. They're just focused on price. Did you have any issues in dealing with the local? You're a national procurer, and obviously then you're trying to get local people in the hospital who are buying the product to sort of, you know, get an understanding of this. Did you have any challenges with them, and how did you get around it?
Numerous challenges, to be honest with you, Brian. Numerous. I've lost count. But however, what we do is we use the benchmark national pathway which we've developed with the said trust.
Yeah.
But every trust you go to is a bespoke project. So you're using your benchmark pathway. But what you can actually do is take their data and drop their data into the pathway to understand what the outcome would be at a local level. Yeah. However, when you sit down with local procurement and have those conversations, you just go through the pathway.
Yeah.
We sit down with them, we go through the pathway, we say, right, this is what happened at the Northwest Trust, this is what could happen in your trust.
Yeah.
And then there's a light bulb moment. Everybody switches on and think, yeah, I get this, because that my patients are not coming back for further surgery.
Yeah. So it's I think what you're saying is, like, traditionally procurement is just obsessed. We're all obsessed by price, but it's by trying to engage with finance people. That's one of the things that you mentioned before. You engage with finance. So you
Yeah.
manage to get finance people on board. So you go on.
Yeah. Yeah, managed to get the finance people on board, as well as procurement and as well as clinicians as well. And I think the main thing is getting everybody in the room and sat around the table and having that, adult conversation, like what Erica mentioned before. Unfortunately, the cost of taking money off a product, say 50 pence here or $1 there, etc., is not possible anymore. So we do need to look at the value proposition of ensuring that patient doesn't come back into the healthcare economy.
Yeah, so it's kind of like trying to eliminate waste, isn't it, in the system? Yeah, wasted effort. The readmissions cost money. Additional treatment.
Absolutely. And the trauma to a patient having to come back for further surgery in this space. Yeah. And also, if you think about it, in the fact that if you're reducing surgical impact, a lot of trusts within the UK can actually generate more income by putting more patients through surgical lists via their waiting lists, and you're actually reducing the waiting lists at the same time.
Yeah, so I mean, again, for the South African market, you've got private and you've got public healthcare. So there's benefits there, and looking at trying to make pathways more efficient, so we can get through greater volume with the resources that we've got.
Absolutely, and it's even just a simple switch of a product or a process can have a huge impact.
But just to sort of we've got a couple more minutes, but have you got any advice that you could offer to SAMA members? So from a supplier perspective, have you got any advice that you could offer them if they're looking to, they're looking at, we talked before about trying to create evidence and things like that around the propositions that they've got. Any advice that you've got if people are interested in looking at value-based procurement and thinking about adopting it, how they could take it forward?
My advice would be is engage with clinicians and try and engage with a key opinion leader who'll be willing to write a case study regards to their experiences, because this is how I went forward in the area I'm working in at the moment, is engaging at that level, engage with people within in healthcare arenas. If you can try and get a key opinion leader within a healthcare setting, like myself as an ODP, like Erica, who's a practicing nurse at the moment, who's got an understanding of the benefits of value. It's key. Collaboration is key. I want to be able to do it without industry. And now, since we've released the project itself, industry are coming to me to say basically, I've got a product which will work in that pathway. And I think within the next 18 months, we're going to have 5 pathways in the primary pathway which have got value associated to it. So we're seeing industry coming to us now to say, I'd like to be a part of that journey with you.
Yeah, I mean, I know the work that you've done. I mean, it's been great over the years. You've been a real advocate and supporter of the of value and really help progress it going forward in NHS supply chain. Just on that note about clinicians, one of the things that I got asked yesterday by a client was about, it's how do we bring procurement and finance in, and my kind of view, I don't know whether you'd agree with it, you can disagree if you want, is that you can use clinicians as a way to try and get people around the table. So once you've got that clinician bought in to your project, which is the first point, it's then about saying, okay, using them and then maybe arranging a meeting then with the finance people and the procurement people to have like this round table discussion, which I think that's what you were saying before, wasn't it?
Yeah,
so
absolutely.
Everyone's kind of quite clear on the benefits across all stakeholders, and then you working together as a team to actually deliver it.
Absolutely. yeah, it's a part of that collaborative approach. It's worked really, really well in the sector I'm working in, and you know, I'm taking it out to other arenas now and other project areas, and it's successful because, again, ultimately, the surgeon or the clinician has a responsibility for that patient. So if he can ensure that he ensures that that patient doesn't come back into his clinic or into hospital or ask further surgery, it's a win-win.
Yeah.
And I think what you've got to do, you've got to be, as they call it in Yorkshire, a dog with a bone. So in other words, you've got to keep going, you've got to keep pushing, you've got to keep motivated. I know it's difficult because, like, for example, you go 30 steps forward and you get pushed back 50 steps, but you've got to pick yourself up, dust yourself off, and keep moving forward.
Right. And on that note, that resounding note, thank you very much, Ian, for your time. I know that we'll probably have some questions. So thanks again for joining us today, and it's really good to see you again, mate.
Thanks very much, Brian.
Right now, a quick drum roll for Jason. He likes a nice big entrance. Come on, Jason.
You do me a disservice, Brian.
Never, mate. Are you going to share your slides, yeah?
I will do, yep.
Okay, over to you.
Thank you. Okay, just let me know if you can see everything.
Yeah, I can see it now, mate.
Yeah, perfect. Okay. So, thanks for inviting me on. I've really enjoyed over the years talking about VBP. And sometimes it's not always been accepted very quickly. Now, we've heard some of the really good things around VBP, and we've heard from Ian there some of those challenges as well. Very quickly, my background, I'm Jason Ram. My background is vascular access. I've covered various countries, every continent, including South Africa, Zimbabwe, Swaziland, and pretty much every continent, talking about various types of vascular access. Expensive vascular access as well, so from ports to ECG, ultrasound, and cannulas, and everything in between. And we've gone from a process from industry, working with healthcare systems, trying to go from a transactional conversation to what we know as a solution selling type of conversation. We're trying to sell solutions and value, and not just a cannula or a robotic arm or an ultrasound. So moving from transactional to solutions encompasses value-based procurement. So all of this work has been done by a number of people. So we're happy to share these bits of information. So from today, what we'll see from my point of view is experience around value-based procurement, the projects that we looked at, the inclusion criteria, what is in, what's out, the process you have to follow, and the outcomes. So we've heard some really amazing things, and I've worked with Erica. I'm working with Erica now, worked with supply chain and Brian, and it's really important from a organizational point of view to have some type of structure. So you'll know in your own systems, in your own organizations, that there are obviously a lot of layers in some cases, and there will be some naysayers. There will be some people within senior leadership, all the way down to salespeople, who will think this is just another fad, it's not going to work, or it's too much work. We've got other things to do. So what I'm hopefully going to show you is a bit of experience around what we've done, what I've done, but also some tools as well to show how we go through that process. So the first thing is that process. It's looking at project viability and the product. So within those pillars, and Brian has probably spoken about this and will share, but when you have a matrix of products or one product, the value-based procurement pillar is thinking about how it can fit into one of these benefits. Does it lower consumption of products? Does it change going from using a bed to a day case? Does it bring about more efficiency? reduction in infection, or being able to move patients from the hospital to the community settings. So these are the kind of ideas that you have to go through in terms of your product portfolio, and really understanding, is it a go or a no-go product? Now, it's okay to say that certain product groups do not fit value-based procurement, and it's true. And as soon as you accept that very quickly, that's where you'll start moving on the right project. So my experience was, we had our senior leadership team in my previous role, and they wanted to put everything into value-based procurement. It was a tick for everything, every product we had. So there were some difficult conversations to say, actually, not everything fits. It has to have a true USP in terms of the product or the process. So the innovation lies in the product or the process. Is it innovative? Is it disruptive? Does it change what's currently being done? Because if it doesn't, that's okay, because you have your commoditized products. You have things that just have to go, and you have a smaller touch point. Where we have those higher value products that can really make a difference, they're the ones that we really want to concentrate on. And that's what we had to do. So we went through a long process, whittling down what was going to be included. And then we had to think about the process maps. What do we do? Who do we work with? What does the pilot consist of? So when we're looking about those commoditized products and those lower touch points where we don't have to spend so much time on contract management, it gives us a little bit more time to work on the more complex projects and the pilots. So the process of really understanding who, what, why, where, the standard process, but why is really, really important. Who's it going to affect? Keeping the patients at the center, and then looking at clinical, department, organization, and healthcare as a whole. And I know Brian spoke about that at the start as well. It's really encouraging to think about and to listen to the results from the questionnaire at the start that Brian shared, looking at 14% being implemented, thinking about value-based procurement, nearly 18% and 23% wanting to engage or implementing change. These are really positive things, because that's past that kind of tipping point that's spoken about. So we can engage with those, and then looking at that 35 to 50% who are thinking about it, really important to try and engage with those people as well. So again, looking at process and time-wise, from our point of view, from an industry point of view, we have to be really specific about what we want to achieve and the time it's going to take, because in certain organizations, you have to deliver to the board or to the senior leadership team or to the sales teams, so they know what's involved. So really understanding when you're going to submit the proposal, how that's taken on by the hospital or the clinical and financial representatives from those hospitals, how that feedback works, and what loop you have to go through to get it back in front of them again. So really understanding from the submitting of the proposal all the way around to moving to implementation is putting some timelines. Now, we went through a process of a submission. I worked with Brian in the very first pilot phases for value-based procurement. And if you speak to Brian, we'll know that it took a long time to get to where we got to. You listen to Erica, you listen to Ian, how long that process has been. I think the positive part for this call and for everyone on this call is that can now be reduced, because all of that work has been done, where we can learn the lessons, we can share those lessons and reduce that timeline, hopefully. So again, looking at the whole process of value-based procurement, and then how do we go live? We worked with NHS supply chain, we worked with the VBP community, and looking at that opportunity and really getting it out there, really getting that message out there. Now, if we're talking about building case studies or building learning portals, it's not necessarily the classic end user case study. It's reframing what that case study looks like in a value-based procurement setting. And it is around clinical benefit, operational benefit, economic impact, and as important as everything else, the patient benefit. So those 4 things make a very, very strong case for change. So it's not just that standard end user case study. There's a lot of information that goes to changing the processes and the minds of the people you talk to. So Erica talks about changing hearts and minds. It is that, absolutely that, absolutely that. So again, something that can be taken away. We went through this proof of concept, looking at value-based procurement, and from project initiation to implementation and measuring impact. I would want you to go away knowing that there are frameworks, there is work that's been done through all of the pilot projects in the UK and across various healthcare systems across the world. But with the help of Brian, knowing what to do, when to do it, and to have someone challenging you. If you do something from an organization point of view, in sort of one way, and you've got no external challenge, you end up having a confirmation bias where you get to the point that you want to get to because that's where you want to be. If you have people like the hospital staff, and you have supply chain, and you have external supporters who challenge you, you really take away the external rocks and detritus, and you really get to the real gem in the middle where you have something that can really change healthcare practice. So we're not going to spend too much time on this, but again, from a sales process, from an industry process, it's really important to go through each of these steps from project initiation to impact. And just as a quick example, you can see each of these, and this is just a snippet. Each of these has a very clear process that we go through. So when we are implementing within our own organization, you know what needs to be done, who you need to speak to, and what the next step is. So what was the outcome of all of this? So, we go through all of this work, we bring people on from industry, from our own organizations, we have the naysayers, we have the positive people. It went through a whole process, but what comes out of this from the point of view of what I delivered with Brian and a few other organizations is something that's hard copy that could change the process. So the initial pilot was through elastomeric devices. We changed the process, which was innovative. We went from filling in a sterile unit to fresh filling on the ward. Now, you would never have heard of this before, and it took a long while to get there, but we did get a document that showed you how to do it and how healthcare providers could implement the process. Now, for us and for me, if I have something like this from an industry point of view that can help support clinical change, it is gold dust. It is something that I would always strive to have something like this. So again, looking at the pathways, what we wanted to do and what I'm always looking to do and what we're doing with Airglove at the moment is looking at what's happening before, and then if we implement, what happens afterwards. And what we found from our patient evaluation is that the summary benefit is increase in operational efficiency, a decrease in wasted costs, and a patient benefit. So we had 87% first-time access, whereas the standard is about 50 to 70%. So we had something very, very solid that we could take forward. How do we change these things? So this is something that we're looking at as well, is providing real flow diagrams, real SOP changes that are solid, that can be taken forward. And we look at the economic impact because a lot of people say, who cares? Who cares about all of those things? How do we implement? What are the real changes? So it takes some work to be able to go and get that economic impact and show that. And this is what we've done with Airglove. And we're not going to say these processes are easy, but they're definitely worth it. And from our point of view, I'm not here to promote Airglove. We're here to promote the idea around value-based procurement. But I've taken that from my previous experience and brought it into my current role. and we know that there's a competitive advantage. There is a true USP to change process from doing things in practice now to creating operational benefit with patient benefit as well. So the last thing to wrap up is really looking at this picture here, is that it is a journey. It is a road that you must go down. However, with all of the work that's been done is to reduce the time of that journey. It was 2 to 3 years when we done it. I did it with Brian. That now is being reduced to months, to a number of months. So if we don't look at VBP now and having that disruptive first mover advantage, we're definitely going to be behind the curve. So as was said already, embrace the journey, find your Erica, find your Brian, you have Brian already, find your Ians, because not everyone's going to be positive. But if you find the people who are going to help you on this journey, it will be much, much easier. And I'm more than happy to share more experiences around this offline if needed. Thank you. That's me. I think I've kept to time, Brian.
I mean, I'm impressed as ever. you never fail, Jason. No, thanks for the presentation. That was really good. And I think, again, obviously, as someone from industry with a wealth of experience and international experience as well, I think hopefully you can sort of add that credibility to obviously what we're trying to put across. So yeah, so thank you very much for all the presentations and for yours being the final one. So now I think it's we're having a panel discussion, are we?
Yes, Brian. I'd like to say thank you, Brian, and thank you to all the speakers that have taken us through. We will go into the panel discussion now just to reflect on the information shared. I can undoubtedly say I think all of us have had something to take away from the presentations. For myself, I think, Erica, we all need to live by the mantra that says nothing changes if nothing changes. That is very important. So it's always harder to break the ground. It's always harder to be pioneers. We all want to get into spaces where things have been done, systems are already in place, and we just fit in. But maybe we are the chosen ones in terms of looking at value-based procurement, in terms of what it can offer for us as South Africa and what we can learn from those who have charted the waters. I think, Brian, that's a conversation we've had. We are here to learn from you guys. And from the lessons, we can also then adapt and characterize it to our own environment. I think, Ian, you talked of systems. You've talked of data, because data is key. So we need to understand and we need to prepare ourselves when we go out there. We need to hold those high-level conversations, because we are talking to people who are needing to buy into what we believe in. And at the heart of it all, as we always say, it is the patient. The cost is a moving object, it's fluid, and cost is relative, but life is the one thing that we want to save. But also we just need to identify that right audience, like Jason, you said, find that Erica, find that Ian within the industry that we work in, hold those conversations. It's not a one-day job. It's not preaching to the converted, because we need to change the mindset, and it's going to require us to knock on those doors more than once, and just sharing those ideas, real life cases like we saw in the beginning of your presentation, Erica. That's what we need to do. So I've just got some few questions that I'd like to pose that we can maybe just touch on. Brian, I know most of the suppliers have bought into the idea of value-based care procurement in principle, but on the ground, we know how it is. We feel that the rules are still written primarily by the buyer, and we have to conform to that. So from your experience in terms of implementing value-based care procurement across the health systems, what is the biggest mistakes that we see, and how can we best deal with that as organizations when dealing with those organizations that claim to have adopted VBP, but in essence are not practicing it?
So I think when it comes to value, what I've noticed over the years is that it's something that I did a lot of work with MedTech Europe, started back in 2015. There's been the industry have been trying to push value onto health systems, or promote value in terms of health systems, and I think it's kind of what you just alluded to. I think there's got to be this felt need for change within your health system. So I think it's trying to find a way to articulate the benefits about what's in it for them, which is why I kind of put that opportunity slide down for your members on the last call. So I think what we need to do really is to try and engage with your health system to make them recognise that there's a need to move from pricing to cost and to total value. And the way that your members can do that is, again, I think it goes back to what I mentioned before, was about having examples that people can really understand about the value that's being delivered, and the reduction potentially in the total cost of care. Because I think for me, that's a real big opportunity. Because I say what we're looking at is a reduction in total cost of care for the patient pathway, and the benefits that are associated with it around the patients and sustainability, and the environment's a big issue as well. So I think there's a lot of work that needs to be done by getting the health system to recognise that value is there, and your members can do that by creating evidence that can be analysed, and people can see it, they can touch and feel it and see that it actually makes sense.
Thanks, Brian. I think, that is the way to go. We just need to customize, make it work. And I think most of us with this value-based procurement, we've got the data. We just need to pull it out there, summarize it, and make it understood or attractive to the other person who's on the other side of the table. Thanks so much, Brian. Erica, obviously, I know buying also does, and the buy-in in terms of value-based care procurement also needs to happen within the hospital setting as well. So I also actually have the same, more or less the same question for you in terms of the buy-in into value-based care procurement from a hospital perspective. That pharmacist who needs to code it, load it on the system, and needs to give one the green light to even talk the product. So how do we go about really instilling and doing that mind shift as well with regards to actually getting the work done?
Oh, that's a great question. Thank you. So Jason had said you just need to find that key person. So whatever the supplier is selling, who is the key person in that area, you need to link in with them and procurement at the same time, because procurement might knock it straight back. But if you've got someone really keen who can see the additional value and work out the different pathway, so there'll be points in the pathway where money is saved, but procurement wouldn't know that because they don't know the, clinical treatment of a patient, for example. So you need to engage with both those people early on. What we've done at our trust is we've got a clinical procurement group. So we meet monthly, and that's my very senior, very serious group with all the matrons on it and directorate managers. So we talk about the product switches that we're doing, and value-based procurement is a standing agenda item because we're making it everyday business. We also have procurement champion network, so we meet with them every other month. So I've got my domestics, my healthcare assistants, all the people on the ground floor, or maybe the junior staff, the lower level staff. They're the ones who can see, actually, I'm spending loads of time doing this, or I've got this product and there's loads of waste. They might come up with a pain point and that'll send me searching, trying to find a supplier who can manage that. And then sometimes we've worked with suppliers with something's not even available. So if we've got a pain point and something's not available, could someone create that for me? Absolutely. Then I have the absolute luxury of people like Ian in supply chain, and I'll just go, oh yeah, what can I do? How can you help me with pessaries, for example? How can you help me with this? Because I am a nurse, I'm a children's nurse, so I am not a subject matter expert in every individual thing. So I've got to link in with those clinicians, link in with my subject matter experts like Ian, who might say, oh mate, I've already done all the work on this. And I'll be like, thank you. Then in the UK, we have the Clinical Procurement Specialists Network. So we as clinical procurement nurses or allied health professionals, we meet every month and we all have a chit chat together and decide, what are we all doing? Each trust does things very differently, which must be so annoying for people like Jason who just want to, implement. And if it works at one trust, why doesn't it work with another? So we're really working with the likes of Michelle Johnson, who is Ian's chief nurse at supply chain. How can we standardize things and make things easier? So we've done a lot of work, but there's still a lot of work to do. But it is hearts and minds. If you bring me a product and you don't believe in your product, I know straight away. And then, my mind's made up. You've got to get your elevator pitch. And the way to get to any clinician's heart is via the patient. So if you can make a difference to the patient there, and don't give up first time. I've failed far more times than I've succeeded. So just keep going. I hope that answers your question. I feel I've rambled there.
Thanks, Erica. You've actually touched on various points which hold the right conversation with the right person, know where the decision makers sit, find them, go have those conversations, know those dates for those meetings that the committees sit once every 6 months or once every 3 months, book your spot, find the right person to hold the conversation with that will take you forward. And that person can be your champion. And that person can open doors for you and lead you in the right direction. Thank you so much, Erica. We are getting a bit pressed for time, but Ian, I cannot leave you out. So implementing value-based procurement in a bigger scale, it might be a little bit compelling. And ordinarily, the phenomenon is that the multinets have the skills, then the resources to implement such, which unintendedly or intendedly might lock out the smaller innovators. How do we move about? How do we avoid such that we don't just block value-based care procurement for the small innovators, but we take everyone on the journey? What would be your input?
Well, there's two sides to this, and I just want to say something as well. I've changed the language of what we use in this space. We're evolution, not change. If you use change in this language, it turns people off. It switches people off. So if you go to a clinician and say, I want to change your pathway, you talk to Erica, everybody really gets upset. So if you use evolution in pathway, it's more softer, it's a more softer approach. And then from that perspective, what we've done in this space, we've actually gone out to market to say, bring your value-based healthcare, value-based procurement projects to us. Let's review them. Let's understand what the benefits are. Reach out to CPSN network, reach out to the clinical networks like I do. I'm in a very, very fortunate position. I've got 6,000 clinicians on tap. I can go and ask a question in relation to a product, an area. Have you used this product, Mr. Smith? And he comes back and says, yes, I have. I've seen very good clinical outcomes in relation to it. So it's first of all, it's having that conversation up front. Changing your language is key in this area. Evolution. And like we say, we have clinics with our suppliers, small medium enterprises, large conglomerates. The project which I've been working on is a small medium enterprise, and they are very, very successful. However, as I said earlier on when I was speaking, we have the large conglomerates now wanting to have a slice of the prize, as you would call it, because they were quite dismissive earlier on in relation to the technologies and how this could move forward. But now people are realizing we can't just look at cost of the product. We can't look at the bottom number on a spreadsheet. We need to look to see how we can create evolution in the pathway to create better patient outcomes.
Thanks, Ian. A lot to take home, a lot to prep, change the language, speak the right language. I think that is key. Know the language that will not smoother yourself through, but to speak the right language that gets the message across. And continuously hold those conversations. Thank you so much, Ian. Jason.
Thank you.
I can't leave you out. Last but not least, as we wrap up, from a supplier's perspective, we are always told, what data do you have to back this out? Research outcomes. This study was not done in South Africa, so even the data that you have is not relevant. It doesn't talk to us. But obviously, we know that these processes, they come at a cost and over time. So by the time you do all that, you have a 2.0 that's already in the market whilst you're still trying to deal with your initial innovative idea or product. So what can you guide us in terms of saying what needs to change within the system so that we are able to deliver an effective and well acceptable, I think, value-based procurement system that is all-encompassing?
Absolutely, it's a great question. I think it's something that that many organisations have to battle with. Is where's the data from? Why is this UK data? It's American data. There's different bugs in different countries, so it's a challenge that can be overcome by engaging with your local hospitals, your local healthcare systems. And this is why it's important to find your positive clinicians who are willing to go and help find that data. Now, even in the best situation in the world, gaining that data, that clinical data, is very, very difficult. Even when you have willing participants, as Erica knows, it's still difficult. So how do we build something that's very, very valuable and efficacious, but doesn't take too long? Because it doesn't have to be a 200 patient evaluation, a high level double-blind study. It's going to that hospital and saying, okay, what are we trying to solve? Can we do 2 weeks, 4 weeks retrospective data or data capture? And then we put our intervention in. So rather than something being 12 or 24 months, maybe there can be something done on a smaller scale that can be extrapolated out in anything between 4 and 12, maybe 16 weeks, which is still very, very short time frame to have data before and after and analyze that data. So it is very difficult. And we know when we go to hospitals and we go and ask for this data, it is very difficult to get it. We just have to keep asking, keep trying. And eventually you'll find someone. You'll find people who will be willing to either share or get the data, and then you can build something small. Once you build something small, you test it at the next place or in the next department in the same hospital, and suddenly you build out a real view of your products, efficiency and benefits to those patients, number one, and to the system. So sometimes starting small and being tenacious is really, really important, rather than trying to get the big national study. And again, changing the language. Case study doesn't always mean just qualitative data. there's real data in a case study where we say we went to this department, we looked at this patient group, this cohort of patients with this type of disease or something, and then this is what happened afterwards. This is what we think will happen over a year. So yeah, I think it's dreaming big but starting small sometimes, but it's really valuable as well.
Thanks, Jason. Thank you so much. Brian, I know you need to drop off, but Nomti, I'm not sure if we will take the hands quickly before Brian, if there's any question for Brian.
Yes, please. We could go ahead and take the hands.
Okay, all right. Amanda, please, Nomti, will you unmute and Amanda, can you please pose your question to the panel?
Oh, thank you, and thank you everybody for such a wonderful session. Great to hear the accents. I really miss, as a Warrington girl, I really miss them. No Model C English, and only the South Africans will get that comment. I think it's really important, following on from what Jason was saying and also what the rest of you have said, that there's a very easy tendency in South Africa to say evidence needs to look in a certain way and take a certain form. And we forget that a case study and an evaluation can be immensely valuable, particularly because it's real world. So I was just going to echo what you said, Jason, and also what you said, Erica and Ian, and I know, Brian, you would say the same thing. Don't give up, guys, because evaluations and case studies are genuine real-world evidence, and they can make compelling arguments and tell amazing stories to our service providers. But I do think South Africa deserves a national health service that really, really works and does well and puts the patient first. I hope that makes sense, Erica. We give up very easily because the buyers, particularly in private, but also public, say the evidence doesn't look the right way. And it almost knocks the humanity out of it, which I think VBP brings humanity back to healthcare.
Thanks, Amanda. A good feedback as well from all of us who are out there and experiencing it on a day-to-day basis. But at least we are equipped and empowered to continue having the resilience to hold the conversations and keep on going back until we see change in our space. Next will be Francois.
Hi.
Hi, Francois.
Good morning. Just from your experience, obviously the one thing none of this addressed is surgeon education, because not all surgeons are equal. So with the value-based care program, we are going under the presumption that all surgeons perform a surgery at exactly the same level, which is obviously, we know, not true, firstly. And secondly is, for this to be successful and measure the outcomes, where is the surgeon being measured for his outcomes and what is he required to do? Because currently in the South African model, 90% of the training of the elite surgeon is being carried by industry. The insurer bears no cost for training, yet he wants the finished product. The healthcare facility bears no cost in training, yet he wants the finished product. And the company or the structure that stands last in line, which is the industry, are responsible for their training. So where does that factor into value-based care? Make no mistake, it's not if value-based care is going to happen, it's when it's happening. So I'm completely on board with the value-based care, but also from an industry point of view, we are always last in the line. We get crunched for less margin, better pricing, yet we are responsible for delivering the finished products. We are responsible. I mean, we're completely different than the English model, but in South Africa, the hospitals don't buy the instruments. The company delivers instruments to the hospital. So the cost model is completely different to the NHS, where a hospital will decide on a product and they will actually acquire all the instruments for the surgeon. So where does that factor into the whole value-based care system? Thank you.
I'm not sure if there's any takers, but from my side, Francois, I think if we go back to Ian's conversation, he talked about systems. So the systems and the pathways that we develop or that we initiate should, in a way, have that inclusion of the right systems, engage and educate. I think if you looked at Brian's first slide, it was engage, educate, resolve. So those all will have to fall within those pathways. But I see, Ian, you have your hand up. You want to take this one as well and input?
Yeah, I can do, yeah. And I think it's looking at how we can interact with peer groups internationally, because, like, for example, a lot of the surgeons do talk to each other internationally, and they do have peer groups. We're quite lucky in the UK that we have strategic policies in relation to surgical activity and what, you know, when you do an operation, you're doing the right operation on the right patient at the right time. We haven't mentioned girth, we should get it right first time in relation to the activity in this sector. So therefore, I understand where you're coming from, but again, come back to Douglas' comment, you need to look at the pathway, you need to understand the pathway and how it operates and engage with these people. Just engage with them.
Thanks, Ian. Brian?
Yeah, a number of years ago, it was something, what you raised, Francois, was discussed in the orthopedic field, where the suppliers there provide training, they provide case cover and things like that. And one supplier was trying to look at what they termed being a hip in a box, but basically then all the services that they then provided. So the hip itself would be, the product itself would be cheaper, but then all the other services, then there was a menu and a price associated with that. And I think that sometimes what isn't clear, and I know this from my personal experience, is that the healthcare doesn't really appreciate the costs and the value that they're actually getting. So I think maybe even if it's trying to articulate in terms of the amount of investment that's required and how it stacks up, so people can actually see the value that they're actually getting by all these you're actually doing. I think there's just a bit of an absence of a real understanding about your cost base and how it all stacks up and how that's factored into the price as well.
Exactly. And now if you look at the ISO regulation, so if I supply instrument sets to an hospital, I need an decontamination certificate by ISO, which sets out certain standards, which basically means I have to do a whole sterilization section at my firm. So what I'm saying is the value-based care is brilliant, but we need to look at all the benefits, which might not always be monetary.
Yeah.
And if I can just add there, this is the point of view from industry, is and I understand your point, Francois, because we are squeezed at every point. You want to try and get in, you want to have a discussion, but this is the price of the ticket of getting in. But we have to come to a point, from your point of view, you're looking at bringing sterilized product into the hospital with no guarantee of revenue coming in the door and time frame, which is really important to industry. So the real key point here is the value. Is you can't push value down someone's throat. It has to be accepted. It has to be two organizations or two people coming together and saying, yes, I understand the monetary value, the patient value, we will use. So before you start spending a lot of money on a healthcare system or a deal, it's having that mutual understanding that we are now in partnership. And if you're not, you move on to the next. And I know it's very difficult. The whole thing is very difficult. But that's the rock and the anvil that industry sits at, is how do we provide and how do we survive? So absolutely. I understand your point.
Thank you, Jason.
Thanks, Jason.
Thank you.
Ian, can I give you 20 seconds? Sorry. You're on mute.
Classic. Just one thing I want to pick up on, Jason. Each pathway has a touch point, and value can be associated to that touch point. So I just wanted to mention that. You know, Erica mentioned it in her presentation. Just look at your pathway, look at the touch points, what is associated to that activity, put a value against it or not. That's all I wanted to say.
Thank you. Closing on a powerful note. Look at that pathway and touch that point. Thank you, Ian. Thank you to Brian, Erica, Jason, and Ian and Erica for taking the time out Thank you so much as a panel. You've shared very practical insights. We all have something to take away. We'll customize it, trim it, enlarge it, shrink it, so that it fits into our various perspectives within our organizations. But it is clear that value-based procurement is not a simple and linear process. It's something that we need to work on. It's breaking the ground. It's getting the right stakeholders around the table. And for us as medtech suppliers in South Africa, I think the key takeaways that I've noted from my side is that it's going to increasingly depend, our success in essence is going to increasingly depend on evidence generation, outcomes measurement, and stronger collaboration. We can't do it alone. It's a collaborative effort, and it's getting the right stakeholders around the table. To the gentlemen and the ladies and those who need to leave, Brian, I know you can drop off the call, but thank you for taking the time out.
Thanks very much again for the opportunity, and again, big thanks to Erica, Jason, and Ian for joining me today. So yeah, hope to see you again soon. Thank you. Bye, everyone.
You.
Thanks all.
Thanks all. Bye-bye.
Bye. We will now move to our second slot, which we've eaten a bit of time. Giles, apologies for chowing into your time, but it was quite a topical conversation that we had there. And in continuing from that, I would like to open our next session, which will be presented by Giles. As procurement shifts towards value, the health economics and outcomes research, it becomes essential. It becomes an essential capability for medtech companies seeking market access. Our next speaker will share insights from the Summit Cienza Health Economics and Outcomes Research Training Series. And I must say, I'm a proud student of Giles. And it was a very insightful session. So for those who are prospects, please do pay attention when he's presenting. It's quite an invaluable series that we went through. We will obviously look and discuss how members can further build capabilities within the health economics and outcomes research field. So Giles is a founder and director of Cienza. He's a professor and is a global expert in health economics, pricing strategy, and market access, with more than 20 years of experience working across the pharmaceutical, medtech, biotech, and health technology sectors. Through his work at Cienza, he has supported organizations that are navigating complex areas, which include health technology assessment, economic evaluation, value-based contracting, and market access strategy. He also serves as an affiliate assistant professor at Northeastern University and is an editorial board member of the Journal of Medical Economics, contributing thought leadership in the field. Today, he will share key insights from the Summit Cienza Health Economics and Outcomes Research webinar series and introduce the Cienza Knowledge Hub, which will offer, which the hub will be offering to Summit members who are willing to take out the series enrollment. Giles, over to you.
Awesome, Fundi. Thank you so much for the introduction. It was a pleasure having you on the course. You did really well. And thank you for the feedback as well. I was just scrolling through the attendee list that's available here on MS Teams, and I see some familiar names. So just a shout out to the colleagues that are attended today. Some of you participated in the course. Others expressed their interest in prior and in the past couple of weeks. And the purpose of today's presentation is to address some questions that may still be lingering related to the work that we did last year and the work that we're going to be continuing in 2026. But before we continue, thank you again to Samed for the invitation to share these 2 points, what we did last year and what we're going to be doing this year. and to add value to the SARMED membership, particularly bridging the divide between theory and attending a course, but its implementation, which is where the true value lies. Nomthi, a quick logistical test. You there? And when I say change slide, would you be able to do that?
I am here.
All right. Awesome. Thank you. Change slide. So what we did last year, by way of a quicker recap, particularly for colleagues that did not attend, is we've covered the application of some of the core concepts of health technology assessment and health economics and outcomes research in the medtech industry, broadly defined. And some of those included talking about HEOR core competencies. If you're a market access manager, market access director, what are the core competencies that should be expected of a professional functioning in this area? In last year's course, the audience was very diverse. Regulatory affairs, market access colleagues, sales, marketing, owners of businesses, new startups, large companies, small companies. So a very mixed pot, but these core competencies are fixed in the sense that the resources that we shared from the International Society for Pharmacoeconomics and Outcomes Research defines a minimum. And for colleagues from, for example, the regulatory affairs field, if they are thinking of making a transition into the field of market access, should consider those as a guiding framework. How that competencies framework is also very useful is to define the capacity that companies should ideally have as a minimum within their organization. So if you don't currently have a market access manager and you're looking at recruiting a market access associate or manager in the future, look to the core competencies, because those will guide you in terms of interview questions that you should be asking to achieve a minimum standard within the field. We also covered economic analysis in medtech. Different types of economic evaluations, cost effectiveness, cost utility, cost benefit analysis, budget impact analysis. We covered decision analysis processes such as decision trees. We touched upon Markov modeling, but not much. That's more of an advanced concept. We also, importantly, towards the end of the webinar series in 2025, spoke about critiquing HEOR literature. So this is a core set of questions that are asked of any published evidence. It can be clinical, it can be economic in nature, that helps you to extract the key pieces of information. We did that towards the end because it's important that we cover all of the core concepts, all of the case studies that we reviewed last year before getting to that. My hope is that those skills have been very useful to supplement the toolbox that you have, the skills toolbox that you have at the moment, to be able to prepare HTA submissions in the future. And the very final webinar was trends and future directions in HTA and HEOR in South Africa. And this is the point that I'd like to just pause on very briefly before transitioning into the next slides. Is South Africa is a very different market. It's as you know, and you know, this is your lived experience on a day-to-day basis. Private sector and public sector, they're driven by very different incentives. That's a very different reimbursement structure, very different design of a healthcare system compared to Europe or compared to South America, North America, and other parts of the world. Meaning that the incentives and the buyers within the private market dominated by one or perhaps two, let's say MedScheme and Discovery Health, but you have a proliferation of many other smaller buyers in medical schemes and medical scheme administrators making independent decisions and determining what is true value for their companies. They are business entities making procurement decisions that impact their sustainability of their business and the financial impact in the future. This is very different compared to European markets, for example, where there is a monopsony buyer in economic terms. That's one single powerful buyer that accounts for 85, 90% of total procurement in a country. Typically, those buyers are making societal decisions that impact the whole of the population across the whole of the market. And as soon as you make that change into more of a societal perspective, you are more bound by policy prescripts coming from Parliament or maybe from technical agencies within the market to drive change. So procurement decisions are very different within their context. Having said that, is all of the core skills that we covered in last year's webinar series, everything that I've described over the past few minutes is equally applicable in Europe as it is to South Africa. However, the emphasis, though, in markets that are significantly different, such as South Africa, and the emphasis that you place on different methods is critical. For example, in a market such as South Africa, as I described the private sector and the emerging public sector under NHI, which was also a discussion topic, there the incentives are short-term, usually budgetary cycles, 1 year cycle from 1 year to the next, when medical schemes are defining their benefit packages. They are driven mostly by financial cost savings, budget impact analysis. If you do a budget impact analysis, it's more likely to have greater traction or more interest from the buyers compared to a cost effectiveness analysis or cost utility analysis. And the major difference between the two is in the latter, you are projecting outcomes for the next 15, 20 years, whereas a budget impact analysis, you are projecting the cost savings or the budget impact for the next financial year, up to 3 years or 5 years in the future. So the methods do not change. The methods incrementally improve as the years go by, but fundamentally they don't change and they are universal. However, the emphasis that you place on the application of those and the relevance to the medtech industry in South Africa in particular is really important and something to take into account. So when you're preparing a Discovery Health submission, for example, and you're putting together the clinical evidence section and the economic evidence section, and you're synthesizing all the available evidence, and sometimes there isn't evidence that's available, always keep in mind is how am I presenting information in a way that can be easily digested for a buyer to make a reimbursement decision that inevitably impacts their financial viability in the future as well. So there is some adjustment needed in the perspective that is presented in the HTA submissions. The course that we ran last year didn't focus, though, on preparing HTA submissions, how to complete the template, what sort of evidence should be collected, how to do systematic literature reviews, meta-analyses, integration, plugging evidence gaps, and so on and so forth. And that's something that could be done in 2026, particularly through the mentorship program that I'll describe a little bit later on. The final point on this slide was about the final survey that was run. There were two, in fact. There was a mid-course survey and there was a final course survey. The feedback was overwhelmingly positive, and for everyone that attended the course, Fundi, you were one of them amongst many other colleagues that are on the call. Thank you so much for the positive feedback. Really appreciate it. We go to extreme lengths to put together pertinent, updated content, publish it on Science and Knowledge Hub. We also run Science and News, where on a daily basis we are updating colleagues and the community on developments in the HTA and the HER field. And we also continue to ensure that everything that we do has a real-world application. As Fundi mentioned at the beginning of the introduction, I serve as an affiliate assistant professor at Northeastern University. The course that was completed last year was designed based on the course that I teach at Northeastern University to PharmD students. So these are fifth-year pharmacy students that are 1 year prior to graduation. So it's a 6-year program. That course was taken and significantly simplified to focus on the key aspects related to medtech and present it as well. And when we find opportunities to also share case studies based on published papers that we have been published and peer-reviewed in peer-reviewed journals, we make those available. And one of those appeared in last year's course, and it's very likely that we'll also update this year's course with more publications that we have in the pipeline. Nomthi, next slide. So these are some of the key quotes from the final survey. The content of the program was great and understood it well. So thank you for the feedback. I'm currently putting an HTA together for a new product for discovery, and I'm finding the content saved on the Science and Knowledge Hub very useful. I've gained a lot of HTA and HER knowledge and skills through the program. Confidence has significantly improved, and also grateful to have been part of this program. João was a great, excellent course coordinator and presenter. Thank you for that feedback. And the last key quote on the bottom right-hand side of the course content was extensive and very insightful. However, due to dynamics at work, I haven't been able to apply the knowledge gained yet, so I'll need to be able to review it. And this is key because it's one thing attending a course and listening to the core concepts, going through the case studies, looking at actually peer-reviewed material that is based on real-world work that is taking place. It's something very different when taking those concepts and then applying it to a project. And this is why we are exploring mentorship programs for 2026, particularly for colleagues that have completed the course and are looking at implementing very specific projects within their companies. And then we would provide mentorship support over the months or years, however long it takes, to implement that project so that the course that you completed in 2025 can be directly connected to a project that you're working on and implementing it. So if you have an interest in learning a little bit more about that, particularly if you receive the certificate of completion and all the certificate of attendance from last year's course, please reach out. I'm very happy to share further details related to that. Once you've completed one project, after finishing the course, then you're off to the races. It becomes just so much easier after that. Next slide. So some of the assessment results at the end of the course, there were 12 participants that completed the 45-minute final examination between those dates that are provided on the slide. The group average was 89%. That is super impressive. The lowest score, if I recall correctly, was 73%. There were approximately 3 colleagues that obtained 100%. So really exceptional work that was done across all of the 10 webinar series. Those certificates of completion were awarded and sent to colleagues. I'll show you 1 or 2 examples in the next slides. There were also certificates of attendance that were issued for colleagues that were able to attend at least 80% of the scheduled webinar series. The attendance was uneven though, and I think it may be related as well to company-sponsored training versus colleagues that were paying out of pocket. And my suggestion is that if you are a company and you're looking to pay for access to Science and Knowledge Hub or attendance in the course in the future for 2, 3, 4, 5 individuals in your company, by all means go ahead and do that for your staff. However, a slight modification to that is agree to reimburse the staff members if they pay out of pocket upfront upon completion of the course, meaning that the incentive for completion is established. The individual pays out of pocket themselves, and then you as a company reimburse from that. Sometimes if it's a company paying for your staff members, that's not really taken as seriously as it should. Think of this as a very good example of an outcome-based reimbursement scheme. Right, outcomes-based reimbursement for education and training. Complete the course and then you'll be reimbursed. Sounds like a typical negotiation with Discovery Health, right? Some colleagues changed jobs during the years. That if you do pay for it out of pocket, though, you will still continue to have access to Science and Knowledge Hub. Nomfi, next slide. This is an example of certificate of attendance that was issued. A colleague's name has been blocked out. This is confirming that they participated and attended the 10 modules that were scheduled. Next slide. This is a certificate of completion, and here the minimum pass mark was 70% for that final assessment. It was an open book assessment, 45 minutes. As soon as they received their email with the attachment of the MS Word examination, the clock started ticking. After 45 minutes, it had to be sent back and recorded on our survey. Our AI agents deployed by the Science support team were tracking all of those as they were coming in. Again, congratulations to the colleagues that completed the 12 colleagues that completed the that assessment. It's really great job. Next slide. So overall, the course was a success, very strong knowledge gains, practical tools that were deployed and are being used. The MECTEC community has been built. And now the key challenge is translating those key concepts and what was provided in the Science and Knowledge Hub in the future via implementation of projects. Next slide. So what are we going to be doing in 2026? Just another 3 slides before we wrap up. Science Knowledge Hub is still accessible to anyone that completed the course last year. Your login credentials remain unchanged, and all of the content that we covered, including the audio, the video, the written articles, which we will update as the weeks progress, you still have access to, and it's available there. If you did not complete last year's course, we are inviting you to obtain access to the Science and Knowledge Hub. We are making it available to SALMED members. The next slide has further details related to that. The design of access to Science and Knowledge Hub is slightly different compared to last year. It is flexible learning platform. It enables you to access all of the content that I've just mentioned. To assist you in strengthening the market access strategies and capacity that you have in the organization. Next slide. All of the content on the Science and Knowledge Hub is scheduled over a 10-week period. The next intake is March this year, so over the next 2 weeks we'll get started. If you have an interest in getting access to it, please reach out and we're happy to share further details. The company email address is there, company@scienza.com, and also the WhatsApp number. Our support team is available to field any questions that you may have. It is a +1 617 219 9400. But there are all the content is there, as I've mentioned, the HTA, HUR in MEDTech, economic analysis, the budget impact analysis, articles, the decision analysis. There are video recordings, audio introductions and orientations, covering of the key concepts. And also we're going to be adding 3 live webinars too. One right at the beginning, and that's the purpose of that little webinar icon in the second column. That very first webinar will be a live coverage of what to expect in the future modules. There is one at week 5, which is to catch up and answer any questions related to the content that is being covered, and one right at the end, which is to support colleagues in reaching the finish line, particularly those that have an interest in completing the certificate of completion. That's that final 45-minute summative assessment. So why the slight change compared to last year? Attendance at live webinars is sometimes logistically difficult. Colleagues are traveling, maybe they're on leave, sometimes they have last-minute emergencies, and if you can't attend, then that's a significant demotivation to potentially continue with the course in the future. Every single week, the content is going to be released. However, you have the flexibility to then be able to read the content at whatever time is convenient for you. Again, you're not on your own. You're supported by all of the material that's there. So if your optimal working time is 2 a.m. in the morning, 3 a.m. in the morning, by all means. If you prefer to do it on Saturday mornings because that's a more convenient time, then that is the time that you have to do. There aren't going to be those live webinars, except for the three that I've just mentioned. But the full library of articles, audio, the video, the masterclass recordings, everything's available there. It's on demand. As soon as you have the username and the password, it's sent over to you, and you have access to that. The cost and this includes the 15% discount to SARMED members. The cost for 12-month access is 2,550 Rand. So just to repeat that, 2,550 Rand for 12-month access. And if you have an interest in having a quick demo of it, please reach out. Very happy to set up a demo account for you so that you can have a look at what's there before you jump into that. So having said that is, again, thank you to SARMED for the invitation to share more with you. And final slide. Open to any questions or discussion points or any final thoughts.
Thanks, Zhao, for the high level outlay of the program. I think because we are a little bit out of time, I will start maybe with saying, can we put the questions, if there's any questions from the audience that they would like to ask in relation to the course, maybe we can just use the 5 minutes and see if there's any questions. Nomti, anything in the chat box?
There was a question, but I think it is answered for Catherine. It said, hi, Zhao, I was unable to write the final test due to being in hospital at the time. Is there any way I can still write that test?
Yes, no problem. Just reach out on email and we're happy to coordinate that for you.
Thanks, Zhao. I think for me, Zhao, I have just one question because most of them you've touched on. For me is for any medtech company or any organization out there, we know that health economics and outcomes research evidence is becoming important. It's the way to go. But building that capacity and ability internally, sometimes it feels daunting. It's not high up in the to-do list. What would you say to that? Why do we need to have that mind shift in terms of how we look at the business models within our organizations?
Do you mean, Fundi, do you mean the capacity for market access within the company? Those set of skills?
For health economics, to have that ability and those specialization within an organization, what would you say within a medtech company? How would that benefit them?
Yes, it would benefit you tremendously if you're able to create that capacity internally with individuals that have the skills to be able to do health economics and outcomes research, particularly the methodological skills that we covered in the course last year. That is usually represented in the form of a market access manager, but not always, because sometimes market access managers have more of a communications role, payer negotiations, reimbursement negotiations, pricing decisions, and less of a technical role. It really depends on the type of products that you are looking at introducing into the market. And let me contrast two extremes. The one extreme is that you're a multinational company, you're introducing innovation into many global markets, including South Africa, and your innovation represents a true value for money. It's true innovation by definitional terms. You would need a health economics and outcomes capacity within a medtech company to be able to define what that value is for the South African private market, maybe in the future for the NHI market as well. That's one extreme. The other extreme is that you're a small startup medtech company, you have a license agreement with maybe a German supplier, and you're under license to then promote a new product within the South African market, there's no evidence whatsoever. The skills of a market access manager in that context over here would be focused on building the evidence, collecting the information, building the relationships. Don't focus though on your health economics and outcomes research, because that's still going to be overkill. You really do need the evidence as a fundamental initial steps. So it depends on where you are, right? And what evidence you have available to support the introduction of your innovation.
Thanks, João. So in essence, it does empower and buffer us as we move towards value-based procurement, because those are also the touch points that you need to encompass as you move through health economics and outcomes research, because you need to associate the cost and the value at the end of it all. As we always say, the patient at the center of it all. And those are the conversations that we need to have with our stakeholders. Amanda, did I see your hand up? Or
you did, Fundi. Yes, I've got a quick question for João. João, I joined the industry, it's nearly 40 years ago, and I started off in pharmaceuticals. And the one thing that I've noticed in health economics and outcomes research is that from the day I ever came into contact with it, it's always been seen as being more of a hurdle than an enabler. And it has not necessarily evolved as much as it should have done to be an enabling and supportive of the patient, if that makes sense, system. What do you think we could do to make health economics and outcomes research lighter? And by that, I don't mean unrestricted. I mean more of a living process that, to Fundi's point, really backs up value-based procurement, but is the kind of process that you can actually go into with a smile, in that it's going to actually ultimately deliver better care for patients, rather than being something that you have to wade through like mud or stumble over like a series of hurdles. I hope that makes sense.
The premise of your comment, and thank you for that, is a question is, what is value? What is value? How do you define value? And if you're honest, is that the answer to that question is multidimensional. It's you can adopt several different perspectives. Notably, a economic perspective, you can adopt a societal or social perspective, social policy. You can utilize a legal analysis to that. In everything that we do in HTA and HUR, I adopt and we adopt an economic perspective to the definition of the term what is value. And this is to your question, is that how can we make it more accessible? It's useful to go back to the basics. The most useful and well-known definition of value was Michael Porter's book in 1985, Competitive Advantage. In that book, he defined what value is, just basically how much a buyer is willing to pay for a new good or a new service. It doesn't have to be an invention. It can be an innovation, something that is workable. Later on, in 2010, he published a paper on what is value in healthcare, and that was published in the New England Journal of Medicine. And if we go back to how value was conceptualized at that time, and this is where it makes it really practical, is value is a health outcomes that are achieved per dollar spent. A value are the health outcomes that are achieved per dollar spent or per rand spent or pound spent. So how do we answer that question of what value is, and how do we make it more accessible? Is that we have these sets of tools that are available, everything that's been covered in the course last year. And now how do we answer the question of what is value? And is it true innovation that you bring into the market? The health outcomes is a clinical evidence component. And the value and the dollar spent or the rand spent is your denominator in the equation. And if we go back to that definition of Michael Porter, I think it's very useful to kind of revisit what true value is. And then the definition of innovation, right? That's is your product that you're bringing into the market innovation? Is it just a me too? And what's the linkage into to premium pricing. If it is true innovation, then it is potentially valuable for a healthcare market and it would command premium pricing. If it is not, doesn't fit the definition of what innovation is, then it can't have a higher price compared to other products that are available, especially in a market such as South Africa. So I hope I've answered your questions, that if we go back to basics and just address these questions of what is value and what methods do we have, which don't change really, to be able to answer that question, then we'll get down to the bottom. And what is innovation? You know, it doesn't have to be an invention. Just on a side note is, what's the difference between innovation and invention? Innovation is something that is new, implemented with the market and used. An invention is just something new, but it's never implemented. So think about great inventions, but are not being utilized within society. Only once you diffuse it through society does it become therefore something that can be reimbursed. And making this distinction in economic terms is very helpful. This is what we cover in the course, by the way.
I get you. I get you how it's that notion of humanness, if that makes sense, and relatability. Yeah. It feels very heavy. It feels very academic, and it doesn't feel human. In summary, is what I'm saying. And I just think I agree with you. Porter's very useful, and I know Brian references Porter as his point of starting as well. But it's just, how can we turn health economics and outcomes research into something that is a lot more user-friendly and delivers compelling, and perhaps it means industry having to think as well, it's not about premium pricing, it's about value-based pricing, because with value-based procurement and value-based care should be value-based pricing. Your price should make compelling sense based on the presentation of value that you have for your product ultimately at the end of the day. But it's the user-friendliness of health economics and outcomes research that I find, or the lack of it, that I find interesting.
Yeah, what I typically advise my students to do is, when you're embarking on this journey of upskilling in HUR and HTA, have a look at the HUR competencies framework. Specifically, how they disaggregate what are the core skills that are required for a HUR and HTA manager in this field. If you feel that you're able to meet those or exceed those, or if you're able to see yourself fulfilling that role and perhaps plotting out a path towards achieving those minimum standards, I think that would address some of your questions of how useful is it, how applicable is it within my organization. Use it as a benchmark, right? Is that where are you today compared to where you should be in the future? And again, those HR core competencies is not what we developed here at Sayenza. These are global standards. And the reflection that they are working exceptionally well is that if you attend an ISPOR conference, compared to 15, 20 years ago, it was all of these old guys, from Europe, I should add, that dominated the conferences, and they were the majority. But now if you go there, it's at least 50, 60% are less than 30 years of age. Young graduates from nursing, from MBAs, from these it's just absolutely astounding. And that's just a clear indication of folks that are willing to embrace these competencies and implement them within their career paths and within the companies that they're working at the moment, which is very exciting.
Awesome.
Thanks so much, Joe. Sorry, Amanda.
Thank you.
We've really gone over time, but I'd like to say thank you to our colleagues who have stayed on the call. And Joe, I know the course. I know what the members will actually gain by being in the course and the mentorship and learning supports that Sayenza provides. I can safely say they'll be in safe and capable hands should they be part of the course. And as we conclude today's Market Access Forum, I'd like to extend our sincere thank you to all our speakers who have shared insights and expertise in their respective fields. And in closing, just to say, as per up the screen, we have various upcoming forums. Please do have a look and do register for the forums. And it does indicate the topics that will be covered in our upcoming sessions. Thank you so much to everyone who has extended their time and their availability. Have a good day further. Thank you so much. Thanks, Nomti. Bye.
Thank you, everyone.